Phaco Cataract Surgery channel. I am Dr. BARDOLOI'S. I am practicing at Jorhat, Assam, India, and this is a very old cataract with a thick fibrotic membrane. We had similar 5 such cases, and we published a paper in Kerala Journal of Ophthalmology, and possibly I am the first surgeon in the world to describe this technique, which I call Phaco capsulectomy. This is my 6th case. I put already trypan blue, doesn't have much effect. Now trying the cystotom, needle cystotom, that also doesn't have much effect. That band is the culprit. You have to get rid of the band. The needle cannot do it. I am trying to find a cleft, but it is not possible because of the band. You may notice in the center of the lower margin of the fibrotic capsule, and ultimately I will have to change my technique. I will have to come out, and we in Jorhat get this sort of old cases a lot, because in our hospital, it is a Phaco training center. We do all our surgery by Phaco, paying or non-paying. So we came out and started Phaco capsulectomy. This is the first bite. We get taking the fibrotic capsule. This is a good bite, and we are taking it. Now we are taking on the right side, another in the center. Now we are taking on the left side, all successful bite. We are clearing the middle a lot. We need more middle space, so that is why I am doing more cutting, which is in fact is sufficient at this moment. Now when the center is free, I will go for actual Phaco. This is a brown hard cataract, and definitely it will be leathery. So I will be using 60% torsion in this Centurion Phaco. I am creating a crater in the middle. That is my technique, which I learned for Dr. Abhay Vasavada, and this crater creation is in fact debulking the Phaco. I will debulk a lot of the Phaco material, and at the same time the crater will help me to hold the cataract to proceed with chopping. As far as chopping I did, this is successful, and the chopping I am using is vertical chopping, and the particular technique is Dr. Vasavada's step-by-step chopping with lateral separation. I like this technique very much. It is a very good technique at my hand, and I am thankful really to Dr. Vasavada that for some reason Dr. Vasavada doesn't use this technique nowadays. He uses multi-level chopping in very hard cataract. This is another chopping I am trying. Yes, now I will have to rotate. You can notice that I didn't do hydrodissection. Still I am able to rotate. This is also the one technique I have invented, hydrodissection in Phaco emulsification. Phaco emulsification without hydrodissection. I developed this technique in 2006, and 2010 I presented a flaming ASCRS conference at Boston, and also presented a paper. That is in 2010, and since then I have been using this technique in all my Phaco surgeries. Probably I have done 35 to 40,000 Phacos without hydrodissection, and in all probability I am the only surgeon in the world to have done so much of cataract surgery without hydrosection. We get this type of old fibrotic cases because ours is the only center in India who does all our cataract surgery with Phaco, paying and non-paying. This is because ours is a good Phaco training center. We train lot of fellows, and also Alcon company has set up a Phaco development program at our hospital. So we are bound to do all cases by Phaco, and this is no exception. In any other setup, this case would have ended up with SICS or ECC, but as we are a teaching hospital, we must promote Phaco, so we have to show to our fellows or trainees that Phaco is such a powerful tool that any sort of cataract, difficult, hard, subluxated, can be done by Phaco only. And as everybody of us agree that Phaco is the best technique for cataract removal. Now the flex has come, but flex also couldn't compete with Phaco. There are very flex doers, but there are hundreds of Phaco players. So I am taking this one, I am taking these fragments one by one. As you can see, the fragments are quite hard, and this is a poor patient. They cannot afford this coat, but we are sure that the technique we are using won't hurt the endothelium much. Of course, some amount of hurting will be there, but not dangerous. So here I am taking a bigger piece, all brown, but at 400 vacuum and 30 AFR with torsion 60 for centurion is not a big task. So here we are taking another big fragment. Look how black it is. I am tempted to name this Phaco as black and white. You can see all white surrounding, and in the middle all black. So this black and white cataract is very nice for me, and I really this type of difficult cases, but because the periphery of the capsular opening is fibrotic, there is absolutely no chances of a extending of the rhexis to the periphery. So I am not careful. I am careful, not careful that rhexis may run away. I am little, you may say, careless, because I know this rhexis won't run away, and I am through the last pieces, all hard black cataract. And you may notice why I am not using this viscoelastics like viscoat or such viscoelastics. The reason is that this costs a lot, and in a free patient you cannot afford viscoat or anything expensive material in a patient like this. And I'm into my last piece, and this Phaco is centurion. It works very well in this sort of cataract. I'm working on the iris plane, and I'm careful that no damage is done to the endothelium. I have done the nuclear removal done. Now the rhexis margin is stable. Only thing I need to do is to implant the IOL. That can be easily done. So here is an implantation of an IOL that patient cannot afford, but somehow we manage this type of IOL that is stromal stool surgery, and we are almost done with the case. So this is our 6th case in Phaco capsulectomy series, and I would let you show the other cases in some other time, one by one. I thank you very much for your patient viewing.